All right. So welcome everybody. Tonight we have a lecture from John Shin, who's one of our PGY4s going into spine. So we have a spine lecture on spinal cord injury that he's going to be giving. So.
Hey everyone, thanks for making it. All right, we're going to begin. Yep, I would like to acknowledge OT and Ortho Blitz for the contents I borrowed. Some of it from those sources. So for a brief overview, we're going to go over the epidemiology first and go over the pathophysiology and classification and the descriptive terms, including the age of classification, and also talk about the function capacity, and we're going to end with natural history. So spinal cord injury, it's obviously, as the name suggests, it's an injury to the cord. The incidence, the 10 to 12,000 per year. It's not common by any means, but it's one of the more devastating spine conditions. And, as you can see, majority of it happens in the male population, 80 to 85%, and usually in the younger people, 16 to 30. So even from that, you can kind of guess that like it has to do with like activities. I mean, like reckless activities, I guess. And 50% of spinal cord injuries are complete. We're going to talk about what complete injury is and incomplete is later. And 50 to 60% of cord injuries are cervical. So cervical spine is different from other areas because it's very mobile and it's exposed. Your neck is, so it's especially susceptible to trauma or any injuries. And the immediate mortality rate after complete C-spine cord injury is about 50%. So it's one of the more devastating cord injuries. And the breakdown by causes, MVCs, the 42% fall accounts for about 1/5, and there is also GSW 16%, and other causes include sports and again more prevalent in the male population. And this came up too in my review. Level of education, college grads have lower, they sustain lower rate of C-spine injuries. So there was found to be some correlation there. And broken down into age groups, you can see a clear trend from 0 to 15. Sports is high, not the highest, but it's higher than in other age groups. It's about 24, like one quarter. And also MVC is obviously there. And 16 to 30 years of age, sports is still there. It's decreasing in about 15%, and vehicle. MVCs account for about half. And as you see older patients, you see increasing amount of falls and less amount of sports. That makes sense. And that's 46 to 60 years of age, about like 1/3 is due to falls, and sports is only accounting for 3%. And even for older patients, almost all is, more than half is due to fall. And MVC is like consistently one of the higher, one of the more prevalent etiology. So employment status after the spinal cord injury, it's one of, I bring this up because it's one of the more devastating conditions that you see. Even at like 10, 15, 20 years after the injury happened, only like less than 50% get employed. So it's not an easy condition to live with if you sustain one. And if you compare between paraplegic and tetraplegic, paraplegia meaning you're paralyzed from, you have neurologic deficit in your lower extremities, and tetraplegia meaning you have neurologic deficit in all 4 extremities. Obviously, paraplegics do better in terms of employment status, but not by too much. So pathophysiology, so we break this down to 2 injuries, primary versus secondary. So primary injury is what's being done at the time of trauma. It involves initial insult to the cord and local deformation, as you can see in this example MRI. and the energy that's imparted from the traumatic event. So there's nothing you can do about this part besides preventing it, I guess. So surgery, the goal of the surgery is to prevent the secondary injury, and secondary injury is due to cord ischemia and compression. Well, ischemia resulting from compression, and it sets off a chain of biomechanical cascade, and there's a bunch of not so good cellular processes that happen to result in apoptosis of cord cells. So there has been many hypotheses, like whether free radical is the one to prevent blame, or if lipid peroxidation is a culprit, or like, so what's causing the apoptosis? It's a constantly evolving area. There's not a clear understanding yet, but we do the surgery to decompress, to take the load off of the compressed cord, to help with the blood flow, and to help prevent this secondary injury. And then, so when you first see a patient in trial bay, there are two things that you need to be on the lookout for. These two are acute phase conditions. The first one is a spinal shock, and it's characterized by transient flaccid paralysis, and the patient's not going to have any reflexes, including a BCR, that is bulbocavernosus reflex. Basically, how you test it, you put your digit up into the patient's anus, and then you tug on the Foley, and then you're going to feel the anus contract. I mean, the anal sphincter tone increase. So that's bulbocavernosus reflex. So you need to do that in all spinal cord injury patients to see if the patient is in spinal shock or not. And this usually lasts for less than 48 hours, but it's unpredictable how long it's going to last for. And this does not, so the presence or absence of spinal shock does not dictate how the patient, it doesn't dictate the recovery course. And another one is neurogenic shock. It's a loss of sympathetic tone. So you're going to see hypotension with relative bradycardia. So normally when you see a patient in trial bay, if the patient's having a lot of blood loss, the patient's going to have hypotension, but the patient will have compensating tachycardia for that, right? But with neurogenic shock, you're going to see hypotension with bradycardia. So this needs to be caught early on to be addressed, and usually you put patients on pressors for this condition. And then next we're going to talk about the Asia classification. This is the standardized spinal cord assessment that we use. So there are 4 steps. So first, we need to determine if the patient is in spinal shock or not. And second, you need to determine the level of injury. Third, you need to decide whether the injury is complete versus incomplete. And finally, you assign the Asia grade. So first, we talked about spinal shock, so we're going to move on to level of injury. So you need to identify the lowest segment with intact sensation and muscle strength at least 3 out of 5. We're going to discuss what that means in a bit. And the motor level, you find the lowest level with 3 out of 5 strength. And in regions where there is no myotome to test, such as like thoracic nerve, thoracic spinal cord, the motor level is presumed to be the same level as the sensory level. So there are 10 key muscle groups, 5 upper and 5 lower extremities, 5 lower extremity muscle groups. So these, you need to kind of memorize it, and like really just, you shouldn't have to look this up, like when you're as a resident. So C5 is elbow flexion, C6 elbow wrist extension, C7 elbow extension, and C8 finger flexion, and T1 is like finger abduction, and L2 hip flexion, L3 knee extension, And L4 is the ankle dorsiflexion, L5 toe extension, S1 is ankle plantar flexion. And then you need to do a sacral exam. This is a digital rectal exam. You use your finger to put it into patient's anus and then tell the patient to bear down on it. And then some patients will not be able to do it, and some patients will. You need to document this. It's very important. So the motor grading scale, it's a 6-point scale from 0 to 5. 0 is nothing, and 5 is the normal status. And the important thing is like 3 here. So when patient can move his or her like limb against gravity, then that's at least 3 out of 5. And then 4 is somewhere between 3 and 5. And some people distinguish between 4 and 4 plus to kind of document like how strong it is, but it's subjective. So we try to avoid it, but some people do. And 2 out of 5 is motion. So 2 out of 5 is you're weaker than anti-gravity, but you're still able to move. So for example, if you put your elbow on your desk and like move it from side to side, just gliding over the desk, that would be like enough strength that is weaker than anti-gravity, but there is something. And 1 out of 5 is it means there's some sort of flicker of tendon or muscle contraction that you can see. And then there's sensory exam. So this is the dermatome on the right side. I'm sure you guys have all seen this in the past. So you need to do 2 things: light touch and pinprick. And you use a 3-point scale, 2 being normal, which means like intact to light touch, and 1 is intact to pinprick, and 0 is absent to pinprick. Then, yeah, you should ideally be checking it for all dermatomes. And then now you have everything you need to fill this out. So this is the motor. So you assign the scores there. Well, on AJA chart, they make you kind of add them up to give it a score, but it's not very useful. As long as you know which level it is, you should be good. So this is the motor on the left-hand side and the sensory on the right-hand side. And then there is complete versus incomplete injury. Obviously, complete injury is worse than the incomplete injury. Incomplete injury means that there's absence of sensory and motor function in lowest sacral segment after the resolution of spinal shock. So first thing you have to do, if you go way back to here, you first have to determine whether the patient is in spinal shock or not, right? So you do that first in any evaluation of patients. And so the easiest way to go about determining this is the sphincter tone test. You stick the finger up into the patient's anus and then have them voluntarily contract. If the patient can do it, if the patient cannot do it, that means there's absence of motor function in the lowest sacral segment. And then you have to do perianal sensation test. Again, the light touch and the pinprick, the sensation exam that we just discussed. Then if they are both like 0 out of 5, well, if there's no contraction and there's no perianal sensation, then you can call it complete injury if there is bulbocavernosus reflex, which means if there's no spinal shock. And otherwise, all other cases is incomplete injury. There's some sparing below the level of spinal cord injury. So this is the AJA scale. So now you have everything you need to kind of like give it as AJA score, AJA scale grade. It's from A to E. A is complete injury. It's the worst. There's no motor and no sensory feedback whatsoever below the level of injury. And B, so A is complete and E is normal, and everything in between is incomplete, B, C, and D. And B is where there is no motor function below the level of injury and there is incomplete sensory deficit. And C and D, it gets kind of tricky there. So you need to look at the how many muscle groups below the level of injury have strength at least 3 or more. So if it's at least half of the key muscle groups below the level of injury with greater or equal to 3 out of 5 strength, then it's D. And if it's weaker than that, then it's C. Okay, and there are about like 4 or 5 incomplete spinal cord injury syndromes that we frequently see, like patterns that we frequently see. So they're kind of grouped, and we're going to briefly touch upon that. The first one is central cord syndrome. We see this, it's the most common incomplete spinal cord injury syndrome. It happens to about, I think, about 1/3 of all the incomplete cases. So the motor loss is greater for the upper extremities compared to lower extremities, and hands are affected the most. They often have complaints with their dexterity with their hands. And you see this most commonly in elderly patients with pre-existing narrow spinal canal. And so prognosis is generally good, and whether to decompress at the compressed level or not, it's still in debate. So it's kind of like dealer's choice. And this is the cross section of the spinal cord, as you guys know. So it's more affected at the center of the spinal cord, and it corresponds with upper extremity motor getting affected more.
John, can you just explain more of why it's the hands and fingers affected versus, you know, your shoulder?
Yeah, so if you look at the cross section of the spinal cord, the ones that are going to upper extremity, the motor tract, the lateral corticospinal tract, the ones that go to upper extremities are more at the center of the cord as opposed to at the periphery. So if the center portion gets affected more, then the nerves that are going to the upper extremity are affected more, so you get more of the upper extremity weakness. That's basically why, like right here at the red portion there, where my mouse is. Yeah.
Thanks.
The next is Brown-Séquard syndrome. This comes up often in exams. Like I think I saw this in my step 1 exam too, but you know, I didn't really see much of these in real life, but it's a cool syndrome to kind of look at. So it's like so it's like only the half of the spinal cord is affected. So you get the ipsilateral motor loss. So ipsilateral is like same side as where the injury side is, and you lose the proprioception from the dorsal column getting affected, and then you lose the contralateral pain and temperature loss because the the lateral spinothalamic tract, they crossed over at the spinal cord level and then they ascend. So that's why it's contralateral. And this you often see with penetrating injuries, and it's pretty rare. The prognosis is surprisingly pretty good for this though. Non-operative, meaning, yeah. Next is anterior cord syndrome. So you see this oftentimes from the vascular insult at the spinal artery. And the anterior spinal artery kind of covers like the front 2/3 of the spinal cord, and it results in motor loss. So the only thing that's kind of spared is the dorsal column, which does fine touch and proprioception. But otherwise, you lose a lot of other stuff, such as motor and like the temperature and pain. The prognosis for this is poor because, again, the vascular insults and the secondary like cellular damage that's caused from ischemia, it's kind of hard to deal with. The posterior cord syndrome is very rare. I'm just mentioning it for the sake of completeness. So the dorsal columns is the one that's getting affected. Only so sensory loss is the major finding, such as fine touch, proprioception, vibration, but otherwise motor is spared and the pain temperature is less affected. This is pretty rare. So point is, you need to know the anatomy of the spinal cord at the cross-section level to see, to know where, which portion is affected. So expected recovery for complete quadriplegia, meaning the injury is at the level above maybe like C5, C6. So C5, because C5 does the deltoid and also the elbow flexion. If it's above that, then you can expect all four extremities getting affected. So this slide really talks about recovery for the complete quadriplegia, the cord injury at or above C5. So the prognosis is bad. There's little chance for functional motor recovery in lower extremities. So functional motor recovery means at least 3 out of 5. And extent of recovery in upper extremities, it determines functional independence because you use your arm. You can, so even when you're paraplegic, even if you're paraplegic, you can use your arms to kind of transfer yourself to get around, use wheelchair, feed yourself, do ADLs. So the functional independence, it has to do more with the upper extremities. And 70 to 85% chance getting at least one additional level. So if you get injured at say C3, then you're getting C4, but that still doesn't say much, right? Because C4 doesn't really innervate the major muscle group. So it's not good. So, and the expected recovery for incomplete quadriplegia. So you have, again, cord injury at or above C5. It's so 90%, over 90% gain at least one upper extremity motor level. So that means if you're 2 out of 5, you're going to recover to 3 out of 5. If you're 3 out of 5, you're going to be recovering to 4 out of 5. And also, study has shown that if pinprick is spared in the same dermatome, there is more than 90% chance recovery to greater than anti-gravity strength. And the most recovery takes place in the first 6 to 9 months. So if the patient doesn't recover much at 1 year time point, then it's kind of safe to say the patient's going to stay like that for the rest of his or her life. So we're going to briefly touch upon the functional capacity. So if you get injured at C1 to C3, you need mechanical ventilation. So C3 for 5 is supplies spreading nerve. So if anything above gets affected, your phrenic nerve is affected, your diaphragm's not going to work as well. So you'll need to be ventilation dependent. If you get injured at C4, however, so there is something going to diaphragm, but you may still need CPAP or BiPAP for nighttime only. And so these patients, they will have affected upper extremity motors for all major muscle groups. So they'll be dependent for self-care and transfers. And they'll need, so they'll be able to move their facial muscles because a lot of them come from cranial nerves. So they will need special controls for motorized wheelchairs, such as mount sticks. And for C5 injury, well, sorry, so this is when the C5 is intact. So if C5 is intact and if everything below is affected, then you are guaranteed to have some deltoid, which does shoulder abduction and elbow flexion. So these patients have some capacity to do simple ADLs, such as eating, and but you still need special kind of device. This is what balance form orthosis. And using that, patient can feed him or herself. But transfers, you just can't do it. And if the intact level is at C6 and everything below is affected, so C6 again is active wrist extension. And these patients can grip, although it's going to be very weak. So tenodesis grip is what you see in this picture. If you take your hand and kind of flex your wrist, extend and flex your wrist, you can see the finger kind of making a fist as you extend the wrist, right? That has to do with the tendons that are going to your fingers, like the flexors and extensor tendons. It's from the So it's not like an active grasp using a muscle, but like rather you're depending on the tendons that are there. So they can do this. It's weak, and this grip can be made stronger with a flexor hinge orthosis. And if the intake level is at 7 and everything below is affected, so C7 is elbow extension. So with triceps, patients can roll over, move in seated positions. They can transfer, they can eat independently, except cutting, because cutting involves your like actively grasping on the knife pretty strongly. Except that they can feed themselves, and they can use manual wheelchair at this point. And for thoracic paraplegia, so if the thoracic spinal cord is affected, if things below T's, so like, let me rephrase this. So if T6 is intact and everything below is affected, that means you have some like abdominal strength to help with your sitting balance, but you would still be like weak in the lower extremities. So thoracic spinal cord injuries, you have intact upper extremity muscle groups, so you can use crutches or walker, and you'll be ambulating with bipedal ambulation with CAFO, which is like knee ankle foot orthosis, and you're going to be walking using the swing 2 gait, which is shown on the right hand side. So basically, you're not actively moving any of the lower extremity muscle groups, but you're going to have the CAFO on to make sure that your ankle is at neutral. So you can kind of swing your body and ambulate like that. But this is, so they can do this technically, but this is very energy consuming, and it's not like meant for daily community use. But they can use wheelchair. So ambulating after spinal cord injury, so there are some requirements for the motor strengths. So you need at least 3 to 5 strength and hip flexors on one side, and at least 3 to 5 strength and quadriceps on the other side. And for incomplete tetraplegics, about 50% of them, they can be community ambulators at 1 year post-injury, compared to about 75% for incomplete paraplegics. So it's a pretty devastating injury, to say the least. Wait, how am I doing on time? So yeah, for the review questions, I'm going to read this out. A 16-year-old male is involved in a diving accident 6 months ago that leads to a spinal cord injury. So you see the theme already, right? It's a young male who does reckless activities such as diving, and yeah, we see this a lot at hospital too. People get drunk, they fall from the porch. This is actually the case I saw. People, they get drunk, they were sitting in the porch, they fall, they injure their neck, and next thing you know, they're paralyzed. It's sad. And anyways, on physical exam, the patient has 5 to 5 deltoid and bicep strength. He has good brachioradialis muscle tone, which is wrist extension, and 5 to 5 bilateral wrist extension. Okay, and then he has 0 to 5 wrist flexion and triceps strength, and he has no anal sphincter tone, absent perineal sensation, absent lower extremity sensation, and intact bulbocavernosus reflex. He has no motor tone in his lower extremities. So what is age or grade? Jeremy, how do we go? Oh, okay.
I was just talking and I realized I was on mute. uh,
Oh,
so what I was saying, you guys, it's okay, I think, to cheat on these if you guys want to pull up on your phone like the dermatomes, because as John was saying,
oh yeah.
over time as residents remember them, but in the beginning there's a lot of to know. So if you're seeing a patient as a med student in the hospital, it's okay to pull it up on your phone
Yeah.
when you're learning. All right. All right. Want to get the answer?
Okay, the answer is C. So we're gonna go go over this question briefly. So so first thing you check is a patient in spinal shock, and it says here that there is intact bulbar cavernosus reflex, which means patient is not in spinal shock. Okay, so now we can proceed to grade patient in terms of ASIA scale. All right, now next let's do the level of injury. So patient does have wrist extension, which is C6, but does not have wrist flexion and triceps. So C7 is out. So C6 is intact. All right, and next, so its level is going to be at C6, and let's go on to determine whether if it's complete or incomplete. So there is no anal sphincter tone, and there is no sensation. So there's like nothing distally, like at the lowest level, which is so this is complete spinal injury. So the answer is complete C6 spinal cord injury. It's an ASIA A. Not good. All right, moving on to the next question. All right, this is a 36-year-old male involved in a high-speed motor vehicle accident. Found an exam to have grade 2 out of 5 motor strength and 80% of his key muscle groups in his lower extremity. His perineal sensation and rectal tone are intact. A bulbar cavernosus reflex is present. His sensation is decreased from a point at the intersection of the midclavicular line and the fourth intercostal space at the level of the nipples distally. That's T4, right? All right, based on the ASIA classification system, what ASIA grade is he?
John, I don't know if you mentioned this before because I was in and out, but
Yeah.
like how you just said, like the T4 is for the nipples, and then
Yeah.
another
The T10 is the belly button.
T10 for the belly button, yeah.
Yeah.
Did you say that already?
No, I didn't say it. No. Like L1's like the inguinal crease. Yeah.
Yep. All right. Here, I'm gonna end it.
Yep, it's ASIA class C. So this question, if you look at it, so first thing you need to look for in the prompt is the bulbar cavernosus reflex. So the patient's not in spinal shock, so we can proceed with giving him a grade. And then you look at the rectal tone and the apparent sensation. Those two are intact, which means that it's not complete. So it's either B, C, or D. So it gets kind of tricky. It takes some getting used to. B is like one step above being complete injury. It is like no motor, but there's some like diminished sensation. But patient did have motor, right? Grade 2 out of 4, 2 out of 5, and it's 80% of the key muscle groups. And between C and D, really, it's the motor strength 3 out of 5 that kind of like differentiates them. If the patient has at least 3 out of 5 motor in more than half of the key muscle groups distal to the injury level, then it's like ASIA D. If it's less than that, then it's ASIA C. So that's why it's ASIA C. All right, next one. Central cord syndrome would most likely be seen in which of the following patients? First one is 67-year-old male following hyperextension C-spine injury. Next, 58-year-old male following penetrating trauma to the neck. And next is 23-year-old male following hyperflexion cervical injury. And next one, 71-year-old male following surgical aortic aneurysm repair. Next one is 19-year-old male without a traumatic mechanism.
Alrighty.
Yep, the answer is number one. So I think we should go through this one by one. So first, so the second one, the 58-year-old male following penetrating trauma to the neck. If it's penetrating injury, it's likely to be. I mean, if the question is asking that, it's likely to be like Brown-Séquard cord syndrome. The 23-year-old male following hyperflexion cervical injuries. So with flexion type C-spine injuries, you see more of a anterior cord syndrome because the vasculature at the anterior part of the spinal cord is most likely going to be disrupted. And next one, 71-year-old male following surgical aortic aneurysm repair. So if something happened, if there's a complication from the surgical aortic aneurysm repair, it's going to like affect the vasculature that's going to the anterior spinal cord artery via the artery of Adam cubics. So that's going to result in anterior cord syndrome. And last one, 19-year-old male without a traumatic mechanism. I don't know what they're shooting for there. So like again, central cord syndrome, you see this a lot in older people with pre-existing canal stenosis. And then usually you see it in hyperextension. So when they fall, they hit their head and their forehead and their neck goes in hyperextension. And then you see this picture a lot.
You often see it in patients with what we call relatively stiff spines. So if they have conditions like DISH or ankylosing spondylitis, those are conditions that you get bridging osteophytes between your vertebral bodies. And so that stiffens up the spine. So then the spine, when they fall and hyperextend themselves, instead of having a bony injury, the spinal cord just smacks into the spine, into the vertebral bodies. So if a lot of times we see patients that there's no fractures on CT scan or anything, but you see that bridging osteophytes, then you want to clue yourself into that. This could be going on.
Yeah, those patients are more susceptible to these kind of injuries, and they're harder to treat at the same time because, like Jeremy said, when there are multiple bridging osteophytes, like you can't just treat one level. So it's like a big pipe that breaks at the middle. So like there are two big lever arms which need to be like kind of held together. So you need a longer fusion. So it's like they're more susceptible to the injury, and they're harder to treat. So it's like doubly bad, I guess. Next, what percentage of patients with a spinal cord injury suffer from major depressive disorder? So this is either you know it or you don't. I didn't know, to be honest.
Yeah, we're all over the place in answers.
Oh. Yep. The answer apparently is 11%. I chose 50 to 75% too myself when I did this for the first time. But the important thing is when you treat spinal cord injury patients, you need to do depression screening, as well as suicidal ideation. It's something that you want to like kind of address for these patients. For other orthopedic injuries, you might not have to ask them. You might not have to be on the lookout for these kind of stuff. But for spinal cord injury patients, be on the lookout. Next one, a 30-year-old male is involved in a motor vehicle accident and sustains a fractured dislocation of the C-spine. On physical exam, he has absent distal motor function, absent sensation, absent erector tone, and an intact vulvocavernosus reflex. Which term best describes this spinal cord injury? Yep, it is complete. So we should go through this one by one. So central cord syndrome, it's something it doesn't fit the picture, right? It's like elderly patient, like low energy fall, usually, and then upper extremity getting affected more than lower extremities. And so let's go. So this is not neurogenic shock. For the answer to neurogenic shock, they need to give you some vitals at minimum, like hypotension and bradycardia. In that case, 4 would be the answer. In spinal shock, this patient does have intact vulvocavernosus reflex, so the patient is not in shock. So it's either complete versus incomplete. And it gives you literally, it says absent sensation, absent rectal tone, distal to the injury level. So it's complete. The next one, following an acute spinal cord injury, a patient presents with systemic hypotension and relative bradycardia. His vulvocavernosus reflex is present. This is characteristic of what type of response in acute spinal cord injuries? So we just talked about it. I probably shouldn't have, I guess. Yep, the answer is neurogenic shock. So going through this one by one. It's not, so spinal shock is when the vulvocavernosus reflex is not there. But his is intact. And a cardiogenic shock, you guys know this from med school. It's the shock. So shock means hypotension, right? Except in the case of the spinal shock, I guess. So cardiogenic shock, so you have hypotension because the heart's not pumping well. There is some issue with that. And neurogenic shock, so it's like hypotension with bradycardia. So you're hypotensive, but your body's not compensating for it by being in tachycardia. So this is neurogenic shock. Hypotension with bradycardia. Septic shock, you guys all know this. You see low blood pressure and tachycardia again, and same thing with hypovolemic shock. So your body tries to compensate for it, but in the case of neurogenic shock, the body just doesn't do it. So they need to put on pressors. Yeah, I think this is our last question. A 47-year-old man is seen, 47-year-old man is seen in consultation in the ICU after being admitted and treated emergently for a dissecting aortic aneurysm. Current examination reveals generalized weakness of the lower extremities with a significant decrease in pain and temperature sensation from approximately the waist down. Proprioception is maintained. What is the most likely diagnosis at this time? Yep, it's anterior cord syndrome. So it says the temperature sensation and pain is decreased, meaning the spinal thalamic tract is affected, which is at like the anterior portion of the spinal cord. And also it says proprioception is maintained, meaning dorsal column is intact. And also there is motor weakness, which means like corticospinal tract is intact. So, and the patient also just underwent emergent treatment for aortic dissection. And so likely it's, I don't know what happened, but likely it's affected the artery of Adam cubics, which supplies like the anterior portion of the spinal cord and the thoracic spine level. So the patient has anterior cord syndrome. Yep, that was it for the spinal cord injury. It's not a fun condition to have for anyone, but these are the basics of what you need to know when treating these patients. Hope you guys took away something from this lecture. If you guys have any questions, just fire away.
Mina had a question earlier.
Yeah.
She asked, are motor vehicle accidents more likely to result in cervical hyperflexion injuries because of whiplash? I don't know if you have anything to add on this. I would say yes, a good amount. Sometimes it's hard to really tell the mechanism.
So with the like C-spine injury for the motor vehicle accidents, it's like kind of hard to kind of show the pattern because different vehicles have different safety features. Some cars have the headrest that kind of pops the front at the time of kind of the impact to prevent the neck from like getting hyperextended towards the back. And in that case, like you would only see like flexion distraction type of injury at the when the body's going forward with the initial impact. So that's that. And also I know that kids in the motor vehicle accidents, if they're younger, they're more likely to sustain. One second, I know this. For pediatric patients, for their C-spine injuries, if they're younger, they're I need to look this up, to be honest. So here's the thing though. So depending on the kid's age, their head size is different. Their head size is different proportion to the body, right? So in the younger group, either upper or lower C-spine is more vulnerable compared to the older adolescents. So I know that's that. And also for adults, they sustain like thoracolumbar injuries from the motor vehicle accidents too. And with the obesity also kind of plays into the role of affecting the so obesity kind of determines where the injury is going to go to as well. More obese patients, I think they sustain more of the upper T-spine injury compared to the less obese people. So those have been shown for sure.
Yeah, and just with when you're talking about kids' head sizes, it's important like to get cervical collars that fit them and kid size, and also
Yeah.
trauma boards
Yeah.
that are fit
Yeah.
kids, because you can hyperextend their neck, or sorry, hyperflex their neck.
Yeah. Yeah. So like, yeah, their head is bigger. So their spine board, there's a small hole at where the head's going to prevent, like Jeremy said, like hyperflexion. And for them, like, so they have more lax ligaments. So even though there's no fracture you see on CAT scan or X-ray, they can still have spinal cord injury. It's called spinal cord injury without radiographic abnormality. So it's a little bit more tricky to deal with PhD spine injuries and to clear them. But that's like a topic on its own. Like, yeah.
And then James asked, can you comment on the use of steroids for acute spinal cord injury?
Oh, so yeah, like there's been a big study called MESCIS, NASCIS. So they, so the goal is to prevent. So goal is again to prevent the secondary injury, right? The primary injury being the initial insult to the spinal cord, and the secondary injury from the ischemia, from the compression causing ischemia, causing like this change in the cellular level. So it used to be like kind of ubiquitous, the use of steroid, like high dose or low dose. There was never a consensus, I think. So but everyone used to like give them some sort of steroid, but it's not been shown to help with the prognosis much. So I know that at Rutgers, at NJMS, even for I mean, at least for ortho spine, like we don't use the steroid routinely. I've never seen it being used, to be honest. If we use it, it's going to be low dose, because steroid can cause like all different sorts of complications, such as like it interferes with body's immune system too. So like if the patient's going for surgery, can have like high rate of infection and healing. So short answer, before everyone used to do it, but nowadays it's like kind of like there's a debate about it. Like, it's controversial, I guess, these days.
Yeah, there's a bunch of conflicting data.
Yeah.
And a lot of times they were initially talking about it was effective in like the first 8 hours from injury. And so that's sometimes hard because patients sometimes present after the fact.
Yeah. Yeah.
And then got another question for you. Are there any chronic etiologies for cervical and thoracic spinal cord injury that are seen frequently?
Chronic cause would be like, I guess, myelopathy, I guess, then.
Yeah.
So like, yeah, it's from like, if you're talking about chronic conditions, it's usually from like degenerative conditions in like older patients. So what happens is, as your disc degenerates, it can like bulge out, giving pressure to the cord, and also as a disc, so disc dries out. I mean, so like degenerate disc, it's dry and it kind of collapses. So as it does that, it puts strain on the posterior elements, such as like facet joints, and they can hypertrophy, and also the ligamentum flavum can hypertrophy as well. So all that causing compression, and that can result in spinal cord canal stenosis that can put pressure on the cord. And the series of symptoms that you see from that is called myelopathic symptoms. And they include like wide base gait, and trouble with balance, and trouble with like dexterity, like handwriting, and stuff. And those injuries, like chronic conditions, even though it's chronic, the prognosis is not good. So when you see patients with that, with the MRI finding of like stenosis, and also with clinical symptoms of myelopathy, then you want to operate on them, because they show like stepwise decline in their function. And then even when you decompress later down the road, like their prognosis, their recovery isn't that favorable. So yeah, that's that.
Any other questions, guys? If not, thanks, John. That was a nice lecture. Um,
Thanks for joining
I
in,
don't know
guys.
when the next lecture is, guys, just given the holidays coming up. So we'll shoot out an email or an update on Instagram when we figure it out. Thanks again for joining, and hope you guys learned something.